A very good morning to all of you. My topic is emerging culprit of post-operative cluster endophthalmitis in eastern India, Acinetobacter baumannii. I don't have any financial disclosure to comment. Endophthalmitis is a serious and vision-threatening complication encountered after intraocular surgery. Cluster infection is defined as the occurrence of two or more than two infections in a single day from one theater or the occurrence of repeated post-operative infection. The incidence of post-cataract surgery infection worldwide is 0.04 to 0.2%. Predisposing factors include uncontrolled diabetes, prolonged operative time, or complicated surgery and breach of sterility protocols. We hereby report the clinical profile, etiology, management, outcomes, and drug sensitivity in Acinetobacter baumannii cluster endophthalmitis. 3 males and 1 female presented to our clinic with chief complaints of pain, redness, and watering associated with loss of vision in operated eye after cataract surgery done 5 days back elsewhere. Vision in operated eye in case 1 and case 2 was no perception of light, and in case 3 and 4 was perception of light present with inaccurate PR. Anterior segment finding in case 1 and 2 was total hypopaon, and in case 3 and 4 was cells 4+ and fibrinous membrane. So case 1 and 2 was diagnosed as panophthalmitis, and case 3 and 4 was diagnosed as endophthalmitis. In all 4 cases, I did core vitrectomy with vitreous biopsy, and intravitreal vancomycin, ceftazidime, and dexamethasone was injected. In all cases, Acinetobacter baumannii sensitive to amikacin was cultured from the vitreous biopsy. Subsequently, 2 cases of panophthalmitis were not intervened owing to explained nil visual prognosis and ended in phthisis bulbi, and rest 2 cases of endophthalmitis underwent repeat intravitreal antibiotics including amikacin. Contralateral eye of case 1 underwent pen-retinal photocoagulation with glycemic control with explained guarded visual prognosis, and the contralateral eyes of other cases were operated by phacoemulsification with PCIOL with good visual outcome. Acinetobacter baumannii is gram-negative bacterium. It is prevalent in hospital settings, especially in immunocompromised and chronic lung disease and diabetic patients. It is spread through direct contact with surfaces, objects, and the skin of contaminated sun. Our case series presented 4 cases of endophthalmitis caused by Acinetobacter, which itself is not commonly reported in literature, and the occurrence of its species A. baumannii is even rarer. Varvares et al. Reported a case of endophthalmitis by this organism as the first clinical presentation of diabetes mellitus, which was found sensitive to colistin. Vitrigen et al. Have also reported 1 such case, which had to undergo vitrectomy 10 days after cataract surgery but had good visual outcome. Only 1 case series of 4 cases from eastern India was found in literature, which was reported in 2009 to 11 by Rao et al. In this series, all the organisms were sensitive to ciprofloxacin and resistant to ceftazidime. Based on their findings, they commented that ciprofloxacin should be considered as first-line antibiotic in A. baumannii endophthalmitis. However, our isolates shows a different pattern of antibiotic sensitivity. The occurrence of this atypical organism in our isolates implies that A. baumannii is an emerging culprit of post-operative cluster endophthalmitis in eastern India, wherein amikacin should now be considered a first-line drug in addition to ciprofloxacin. 2 of our patients had uncontrolled diabetes and hypertension, hence the role of systemic control for the prevention of endophthalmitis and thorough preoperative preparation cannot be overemphasized. Endophthalmitis should be differentiated from TAS also. So my take-home message will be A. baumannii is a very rare cause of common source endophthalmitis, which needs close epidemiologic monitoring with poor visual and anatomical outcomes. Hence, prevention is key. Management of endophthalmitis includes immediate intravitreal antibiotics and timely referral to higher center for vitreoretinal intervention. Amikacin should be considered as first line in sensitive Acinetobacter baumannii isolates.